Well, good afternoon, everybody, and welcome to this EPR Network webinar. We'll just give people a few more moments because it's not quite 12 o'clock yet, but if you'd like to put in the chat who you are, where you're from, and your role within the EPR ecosystem, that would be great. I think we're going to share various comments, etc., in the chat as well, LinkedIn links, etc., for the team. So feel free to do the same, and we'll give just another couple of seconds before we make a start. Right, well, it's dead on 12, so let's make a start. So good afternoon, everybody. Welcome to this EPR Network webinar series. Brought to you from Healthcare Innovation Consortium. We proud curators of the Electronic Patient Record Network. I'm Hadley Stoller, I'm the Chief Exec of HIC, and I'm thrilled to be joined here today with Andy Miner, who's the CEO of SI², and you'll be hearing more from Andy as we go through. Today's topic in this series that we're running is around getting more from your EPR, with a particular focus on business cases and procurement lessons for what's ahead. So I think there's some housekeeping slides just to go through, which won't take very long. So if we could bring those up, Colleen, that would be great. Oh, they're gone. Okay. Well, anyway, I'll just talk through the housekeeping bits while that get sorted. So there we go. So we won't be able to kind of hear or see you, but there is the chat functionality that we would encourage you to use. For those of you that have just joined, please do put your name and where you're from in the chat so that we just know who's with us. Any questions that you'd like to ask at any time, we can see the questions coming in. We might not get to them all, and we'll try and get to them when we can. Obviously, this is being recorded, and you will get the link within 24 hours, and you'll also get the slides on email as well. So just very quickly, just a little bit about us. So we're an independent consultancy. We specialise in digital health transformation. We partner with organisations across the country to deliver that evidence-based, strategic, sustainable and digital solutions to improve patient care and workforce efficiency. We focus on readiness and maturity assessments, understanding where you're starting. We offer procurement advice to define the right specs. We pull options appraisals together. We work on implementation and utilisation support to ensure systems and technologies are deployed and optimized in the right way, and we wrap it around a benefit realization model. And you can see just some of the organizations that we work with, everything from life science organizations through to ambulance trusts, community interest companies, acute trusts, and all in between. So that's just a little bit about us, and we're really proud to have brought this EPR network and community together. We provide this as a real space, for healthcare leaders, suppliers, vendors to collaborate, to share learnings, and to really kind of, start to influence the conversation and help to overcome challenges and opportunities as a collective voice. And obviously, we host a number of events, including the webinars and webinar series, of which today is part of, and in partnership with Convenzi's group, we also run and host a number of kind of regional and national events, in particular on this topic within the EPR space. Some of you may have come to the EPR summit that we ran in February. There'll be another one next year, and this November we're also coming to Wales, and next year, as well as England, we're coming to Scotland, Northern Ireland and Wales too. So look out for those dates if you're interested in speaking, attending, or support it. So that's a little bit about us. That's a little bit about the network. So without further ado, I will hand over to Andy, long-term and long-time friend, colleague of myself and HIC. He's the CEO of SI², System Integration Squared, and he's the co-chair of Open EHR UK. So Andy, I will pass over to you to give us a little bit of context of the story behind SI Squared.
Thanks, Adley, and yeah, good afternoon, everyone. So I'm a long-term veteran of digital health. It's all I've ever done. 35 years, actually, always on the vendor side. Started off as a developer right up to kind of managing director level at various vendors. And I think I wrote some of the first HL7 interfaces in the NHS back in the early 2000s. And so for about a quarter of a century, I've been really interested in interoperability and how to improve data sharing within the NHS, which has always been a hot topic. So I set up SI Squared just over a year ago with the objective of raising the bar on interoperability, mainly by getting vendors to work more closely together, hence the name System Integration Squared. Yeah, so that's me. Yeah, I'm looking forward to chatting with you, Hadley, about how we can get more value out of procurement.
We're going to have a good chat, aren't we, Andy? We're going to have a good chat. So there's a couple of different areas of focus that we're going to look at. Interestingly, Andy, just for your information, we've got some couple of colleagues actually from ambulance services on the call. Some of them are looking at procuring, defining specs for their EPCR systems. I had the privilege actually to work with a number of ambulance services quite a few years ago on those exact programs and rolling them out. So I understand a bit about the nuance of an ambulance service EPR versus a trust EPR. And that's something that previous webinars have picked up. So maybe bear that in mind as we're going through. So a couple of different areas of focus. Just for those that have recently joined, if you've got questions, comments, please put them in the chat. We've got the EPR network team in Rhiannon and Colleen monitoring and commenting back and feeding those to us. So, please do interact with us through that. So, Andy, we're going to try and make this as informative as we can. I appreciate that some of these topics can get quite technical and people may not necessarily understand some of the nuances. So we'll try and make it as easy as we can. But I think it's fair to say that given the Data Use and Access Act of 2025, which people may not know about, it's clear that interop is no longer an optional kind of add-on, and obviously with the single patient record as well, standards in particular becoming enforceable from that software piece, to the strategic architecture. So where's the balance between kind of buying functionality and buying future data liquidity, and actually what does that mean, and how should boards across the country kind of measure it?
That's a good start question, Hadley. So we start with what is data liquidity, because it's a bit of a jargon word. It just means that data can move like liquid between different systems. So it essentially means that you've got the right data at the right time to the right person. So it's not being locked in to a system. So I've responded to dozens and dozens of tenders throughout the years, and there's not really been much, I would say, much change in quarter of a century around the interoperability space. And one interesting thing that I think, if you'd have said 5 years ago, I actually travelled the length and breadth of the country speaking to NHS organisations about data and data quality. And there was just generally a bit of it's data. So data wasn't really considered as an asset. Whereas I think since COVID, and then of course the advent of AI, because everything's AI, now everyone's talking about data because they need it. So where's the balance? I still think that there is a balance, because when you go out to buy an EPR or a digital platform of any description, you're really focusing on functionality. The focus a few years ago, and in some cases still, is to get rid of paper. So it's just literally removing the paper from existing processes and digitizing processes. So there's a real focus on functionality and what the system can do for us today. So does it solve pain points in clinical workflow, etc., or improve efficiency? these matter. I mean, these are incredibly important, but they're today's problems. But if you only buy for functionality, you risk locking yourself into a system that does what you need now, but you can't move forward, take advantage of all the new technologies that are coming through. So future data liquidity, as I said before, means you can easily move, share, and use the data across your so not just now, but in 5, 10, 15 years time. So patients live, the average life expectancy is probably about 80 years. So your data really, you need to think for an individual, well, how am I going to look after it for 100 years? Yeah, and no system is going to be in place for 100 years. So the balance is really about the short-term clinical and operational utility versus the long-term data freedom. And I think there's too much focus at the moment on that short-termism, immediate functionality, and not enough on the data side. But it's hard to measure on a procurement spreadsheet. So, as I said before, I've responded to lots of tenders, and around the functionality, there's sometimes hundreds of questions about very specific things on around functionality. But when you get to the interoperability section, it's just are you compliant with these standards? It's more of a 2 or 3 questions, and where have you done this before? It's not really enough. So I think how boards should be measuring it is asking a few very practical questions, which is, does your system comply to open standards, for example, OpenAir, FHIR, HL7, but also the vendor model. So some vendors are different to others, so there are many vendors out there. Some of those vendors, certainly the more modern ones, they put interoperability at the core of their offering. So they see the data as your asset, not their asset, which I think is really important. Another one is, how much is it going to cost to get your data out of the system? So I was managing director of a well-known data migration company. So I know there's data migration is a big business, because it is so hard to get data out of these systems. And then, can you reuse the data? Is the data, can use it for secondary purposes like research, AI, operational planning, without this huge rework? So I think boards need to start thinking of data in the same way they think of financial assets. You wouldn't put all your reserves into a bank that locked you in, restricted withdrawals, and gave you no visibility now, would you? So why do you do it with your clinical data? So for me, closing thing is, functionality gives you short-term returns, but data liquidity gives you that compound interest. And if you get that wrong, you'll be paying for decades.
No, you know what? Some super interesting themes there, Andy. So obviously, and for colleagues, on the call that are thinking about, EPR specs and procurement, it is about thinking, AI, and we'll talk a little bit about AI later, I guess, but, AI is here and it's able to do things with data that we couldn't perhaps do before. So that's another kind of lens that we're now looking through. And, you just said it there, it's kind of hard to get the data out. So, whilst you may not know what you want to do with that data, and whilst you may not know what the answer is and what the world looks like in 3, 4, 5 years' time, if you're about to procure a 10-year, EPR system, don't just have the mandatory tick box, requirements on that spec, but actually think a bit more broadly about what you might want to do and have the ability. And we heard from Hill Dickinson on their webinar a couple of weeks ago about ensuring that contracts are also future proofed for the same thing. It's not just saying we want to be able to do X, Y, Z, or we may want to take the data out, but actually making sure it's contracted as well. So yeah, lots of really good, interesting thoughts there. So, if that, and we didn't really talk about it in too much detail, but this Data Use and Access Act of 2025, if it makes standards enforceable, what kind of single commercial lever would you use in procurement to guarantee that the vendors actually, prove interoperability and not just kind of promise it?
So I think it's about the problem is at the moment is it's just like you say, a tick box exercise. You know, are you compliant with FHIR? Are you compliant with open air? Which is kind of meaningless, because it's like saying I've got a I've got a tool, I've got a spanner. It doesn't say how, whether you're any good at using it and how you use it. Yeah. So if I had to do just one thing, one lever, it would be, make contracts award contingent on, passing some sort of independent conformance plug and play testing against open standards before that final, payment milestone. So that becomes less about, saying what you do, but it's actually proving what you can do. So not just saying you can interoperate, but show that your systems can exchange real patient data in a controlled test environment. These test environments don't exist at the moment. That's the problem. Interoperability by its definition is a multi-party thing, but it's always the only time it's really done is in projects in a live environment, normally when a customer says, I want this. So I think doing it beforehand and having that proof and having a certification that isn't a tick box exercise, it's witnessed, repeatable, and aligned to the standards bodies, and having the payment structures linked to that outcome. So if you can't demonstrate that if you can't put your money where your mouth is, basically, you don't get your money.
And that goes back to the contracts, doesn't it? I'd be interested if people in the chat might want to put whether they've considered that, kind of financial kind of milestone and linked to payment, because I think that would possibly change some perspective, wouldn't it?
I think so, yeah, and I think it just works commercially as well, because it's one of the few levers that the boards really can control, procurement. So by tying money to demonstrable outcomes, you're de-risking your delivery, you're leveling the field. So some of the smaller vendors, that sometimes don't get a look in, they might have slightly less functionality but much better interoperability, which in the balance of things, going back to my earlier point, and it kind of future-proofs your investment. So whatever functionality you buy today, you're not going to be stuck with forever.
So, absolutely.
So I think it's show me, don't tell me is the message.
And there's just a quick question before I move on to my next question, just in the chat, actually, from Tom, who's from the Clatterbridge Cancer Centre, just asking about any lessons on convergence business cases. So almost a step before the procurement, and the activity and transformation benefits definition for convergence in Treasury business cases, especially in a block contract context. So, when you're writing that business case, how do you allow for that activity transformation and benefits, from a convergence perspective? Maybe think about it, but it's
I'm gonna have to think about that one. So from a convergence, as in reducing the number of systems and merging systems together.
How do you define that convergence and the benefit wrap around it? I guess if we boil that question down, it's actually what are the benefits of interop, and how do you demonstrate it?
It's a good question. So the benefits will be, so the benefits of interop are normally not just, and I think this is probably one of the problems with it, is it's not always the procuring body that will get the benefits. It's quite often it's a system benefit. So you have to have that kind of look at the whole system, because the benefits might be in another, and that's where it starts getting tricky with business cases. But it's still the right thing to do, and if we don't shift the dial on that, we're always going to have the same problems. But it's a great question.
No, good. Hopefully that answers your question, Tom, but obviously feel free to put something else. So I mean, in terms of just picking up on those benefits again, Andy, just final question, like what would you say would be an immediate benefit, or do you think it takes longer? Could you say after 3 months this is what we've seen, or is it more over the 3 years we've now seen the system, the ecosystem benefit? Because obviously there's the change of landscape too now with ICB clusters and mergers, etc. So it might become harder to actually track those benefits, or it might actually be easier because the geographies are much bigger and much more defined than perhaps they have been before.
So I think there's with all benefits realization after 3 months, you're not going to see the entire business case realized. So it's going to be some key wins, some quick wins you're going to be looking for. Some of those may be around interoperability, or they might be around functionality, but there might be, for example, another organization that data sharing wasn't very effective with, that now is enabled because of improved interoperability. So I think it really is on a case-by-case basis. But having for example, greater patient engagement in a process made possible through interoperability, that's a great benefit straight away. Patients are can be more involved in their care planning and care process, and that can't be done without better interoperability.
And it's also about understanding the baseline, isn't it? How are things working now? What's not joined up versus what does what does good look like now that these things are in, and that's how you start to track, isn't it, and measure impact. So no, it's really helpful. So in terms of the second kind of theme, I guess, that I wanted to quiz you on, Andy, so kind of managing expectations around procurement. So the importance of building time for complexity in procurement, particularly around the fact that interop is kind of no longer optional. How can trusts integrate digital interoperability maturity models into tight OBC, FPC timelines without derailing approvals? Because obviously, if it goes from a tick box on the spec to now a much more established and mandated component and part of the jigsaw, we know how long these business cases take now, but with added complexity, what does that, how can trust look at doing that, and what does that mean really?
Yeah, it's a good point. You don't really want to make things more complicated than they are, but I would argue possibly that it wouldn't. And I suppose the worry is that adding a kind of maturity model, interoperability maturity model review could slow things down. But the reality, I think it could almost be the opposite if it's done well. It could accelerate the business case approvals because it strengthens the evidence base and shows alignment with national policy. So I think 3 ways you could look at this is do a lightweight early assessment. Don't wait until the OBC or the FBC is fully drafted. Do a rapid interoperability maturity model light review right at the start of the options appraisal. This that'll give you a clear baseline and highlights integration risks early, and that I would say is a couple of weeks exercise, possibly 3 weeks, not a 6-month diversion. And align the outputs to Treasury language. So map all the findings from the maturity model into a 5-case model. So strategic, how the maturity supports national interoperability aims, economic, risk-adjusted costing. So integration costs always balloon if not called out. It's anything that's not, you're going to be dealing with the sharp take a breath, it's going to cost you this much, Gov, when you're getting things done. And I've got experience of that as well, having worked with some of these integration managed service providers. So the third lever being the commercial, so contract levers time to interoperability outcomes, financial, so the whole life cost savings. That's really important. I think over the life of the contract, the savings, and that's harder to accurately estimate, but what would those whole life cost savings be through data reuse, through secondary use of data and things. And then management, so the governance for sustaining that maturity. So, and this way, a digital interoperability maturity model, it isn't an extra, it's embedded in the very way the structure the Department of Health and Social Security and the Treasury expect. So and then use it as an assurance tool. So position this review as part of the Gateway Assurance Pack. Boards and regulators will love that because it shows you've objectively tested integration claims. So you're not just relying on the vendor promises, because that's the reality at the moment. So I would say if you do this review tightly, it's tightly scoped and aligned to the business case structure, I would say it de-risks approvals because Treasury and NHS England will see you've qualified that integration risk. It builds credibility. It looks proactive rather than defensive, and it saves time further downstream. So there's far fewer please clarify loops once the full business case is submitted.
Yeah, and actually, and not to kind of dwell on things that haven't necessarily worked, but that's where we get the most kind of learning, isn't it? Really, where have you seen kind of federated analytics or AI pilots stalled by closed EPR architectures, and what lessons can we generalize from that?
I haven't seen a huge number because I don't think there's that many. I suppose areas where the shared care record program has been hugely difficult to get quality, good quality structured data from some of the systems, especially around areas like mental health and community. That data is difficult to get hold of. In some of the what I was going to say, some of the AI projects are certainly at risk because, again, getting that good quality structured data is an issue. And I would say the reason I was thinking that it's not always just a technical thing. There's also the kind of IG, which is slightly different, but I know really good startups that have just looked at getting data out of primary care, for example, and just given up. So even though it's technically possible, although difficult, the IG on top of it is just not scalable. So I think it's a difficult one to put on exact cases I've seen, but there are many of them.
Yeah, no, that's good. So what would you say is like the most common way that vendors kind of overpromise interop? You alluded to it before, and I know you also spoke about this in your answer around, including it contractually, etc. But if interop is legally enforceable, what penalties should apply for non-conformance?
Well, I think it's probably fair to say something, why would it be different, to say clinical safety? So if a system wasn't clinically safe, you wouldn't use it. So to give it on a similar, I'll put it on a similar standing to something like clinical safety or data privacy, data security. So all of these things are, in fact, part of DTAC. So DTAC, as I was saying, these things, usability, clinical safety, cybersecurity, interoperability, all of these things are equally important. So I would put it on the same sort of level of that. At the moment, vendors, when you respond to tenders, they'll all say, yes, we do interoperability. They'll all say, yes, we're FHIR compliant. Yes, we're HL7 compliant. Yeah, but even in the states where these acts are being passed, like the Cures Act, and large American vendors have been forced to do interoperability, it still feels like it's a tick box exercise. So yes, they do this, but there's charges around it. There's a shortage of resources. The documentation isn't very good. They just make it difficult. It's not a natural thing. Whereas I look at some of the other vendors normally coming out of the Nordics and Europe, interoperability is at the core of what they do, and they're doing large integration projects. And you see some of the more digitally mature nations, such as the Nordics, moving away from single vendor monolithic systems to a more open ecosystem of different systems exchanging data.
Yeah, no, absolutely. So yeah, and it's great to have those case studies and to have those kind of exemplars, isn't it, from outside the UK to see what good looks like in other parts of the world. So obviously we've spoken about the standards, the contracts, the things to look out for, the timelines, measuring the benefits, but and the architecture. But I guess let's kind of talk for a little bit about what I suppose what really matters and what people are kind of wanting from these systems, which is kind of delivering value beyond go live, but while managing those risks really, so that long-term benefit isn't kind of derailed, right? So, what early benefit milestones, so say the first 3 to 12 months, would convince execs, and boards that EPR is delivering return on investment, early and beyond that initial go live.
Yeah, I think that's a really good point, because vendors will because they have to, because it's competition. When you're responding to a tender, and there's only the words you put down, so there is a tendency to really possibly oversell the impact. But the reality is that the first 3 to 12 months, the focus, I think, should be on kind of 3 areas. First thing is the operational efficiency. So for an example, is the reduction in duplicate tests. So if a patient is the default is, if they can't find a test, they'll order another one. So maybe that test was done at a different organization within the same patch or very close. If there's no interoperability to be able to see that, then there'll be a duplicate test done. So a reduction in duplicate test, faster discharge summaries, fewer transcription errors, elimination of paper still, paper workflows, where if the systems don't interoperate, it's inevitably a piece of paper or an email is just as bad, really. So so all that matters, because execs will see cash saving benefits or capacity gains early on, so that will free up staff time or reduce backlogs. The second thing is around clinical safety and quality. So being able to reconcile medications with fewer prescribing errors. Allergy alerts is a great example. If allergies are just locked into one system, or there's multiple versions of a patient's allergies within a region, that's just clinically unsafe. So what the solution should be is one source of truth for the allergies within a region or an ICV or something, and all the systems being able to look at that and update it. So and then generally being able to improve handover. So handover for transfers of care, for one, is always an area of risk. So that's the natural points where interoperability comes into play. So it's around those areas I'd be looking to see so immediate benefits. And then just the third one is just around data visibility to support decision making. So being able to use the data to create system-wide operational dashboards.
And he's frozen. Oh, Andy, sorry, I think you just froze there for a second.
As well.
Yeah, sorry. Got a file dashboards.
No, I'm back. So
but you're back in the room.
Okay, thanks. Yeah. So the data visibility for decision making. So real-time dashboards, theatre utilization, bed availability, emergency department wait times, things like that. So it's giving the execs having insight that they've never had before. And it's important that they can create their own dashboards, not just use the dashboards that are given to them by the vendor.
No, it's really good. And that kind of touches on what you were saying before, doesn't it, about future use of the data, what else you might be able to do with it, presenting population health level data, as well as a unified view of a patient, for example, meds or allergies or whatever it might be. So that's about kind of maturing what's already there, isn't it, and kind of working out how to best kind of utilize that new solution, and equally trying to kind of think about those structural organizational changes and how that might impact on future capability and functionality, and the need for those standards to be in place to make sure that when that kind of expansion does happen, that it's done safely. So
absolutely.
How can trust integrate with an interop kind of assessment model, in tight timescales, without kind of derailing approvals? I know we kind of broadly, spoke about that before, but is there anything else you want to add on that one?
Well, I think I'd probably shift it a bit and say, at the moment there's a tendency to to go out and buy a big box, as much functionality in one area. And that kind of, and that's really the way that the capital's, issued out. There's a tendency to go for that. So I think the shift needs to be away from complete monolithic solutions towards modular open platforms. And I think that's part of that, having that interoperability review, maturity model review as part of the business case and procurement process will be a catalyst for moving towards that.
Yeah, absolutely. So if you had a kind of a magic wand to change kind of one, NHS capital approval rule, because obviously we know there's lots of them, and they can cause a lot of stress and add in time to the process. That maybe unintentionally incentivizes closed EPRs. What would it be?
Oh, if I had the magic wand, I'd change the way the capital approval kind of rewards this complete solution. So I think that's what I'll say. No, I'd switch it towards open modular platforms. So the business case scoring and approval process, vendors seems to favor vendors. Sorry, can't get the words out. Will deliver everything you need in one box. That seems to be the way that the money's the preference at the moment. I think that looks less risky on paper. One supplier, one contract, one line of accountability, or my favorite line, one throat to choke. It unintentionally incentivizes these closed data models that lock data in, and it stifles innovation. So I think I'd reframe the approval rules so that openness and standards compliance are scored as risk reducers, not risk multipliers. So in other words, if a trust proposes a modular approach with multiple vendors and those vendors can prove their interoperability, they should be treated as lower risk, not higher risk. And business cases should be required to cost in exit scenarios. So how much does it cost to get your data, same thing, out of the system in 10 years time? And if that cost is huge, then that should penalise the business case. So, and I think these approvals should explicitly weight future data liquidity. For those reasons I said earlier, data is an asset and should be treated like a financial asset. And I don't think NHS organisations are doing that at the moment. They're still focused on the functionality. But the ability to reuse data across research, AI, system-wide planning, and as a benefit in its own right. So the irony is that the current rules were designed to make the Treasury more comfortable, but they end up pushing trust towards solutions that feel safe on day one, but then become hugely expensive and rigid in the long run. So I don't think the balance is right. So if you flip the lever and encourage the market to compete on openness, that's where the innovation and the value is going to come from.
Yeah, no, 100%. And by the way, just to kind of remind people listening, if there's any questions, comments, please do add them into the chat. I know we're talking about a lot here, and there might be things you want to just kind of ask Andy or myself. No, that sounds really good. Thanks, Rini. Good to see you. So I guess how can this, because it feels like from what you're describing that actually. There needs to be much more expertise, possibly much more kind of time given within trust to look at these things, not just when you're procuring, because obviously that's when it isn't too late because you're just starting out. But even once these systems are live, this is you don't just do the assessment and then it kind of finishes, do you? It's an ongoing, it's an ongoing conversation. So how can kind of baselining, through a digital maturity tool, interop maturity tool, how can baseline reduce that kind of vendor lock-in risk if things just aren't working and those standards aren't being met and the interop isn't doing what it should do? How can you reduce that risk?
So I think I feel very strongly that that the answers aren't going to come from the centre. So there are there isn't going to be, this is how you do interoperability from NHS England digital, whatever. So I think it has to come from the vendor community. So a digital interoperability maturity model. I think that will reduce that lock-in risk, because it normally creeps in through the back door. It's not just about the contract clause, it's about where the data lives, how portable it is, and whether your architecture supports substitution. So if you can't reuse your data without massive re-implementation costs, then the vendor owns you, not the other way around. So I think a maturity model would help, because it kind of shines a light from the start. And if you had considered a kind of 5-stage maturity model, where level 1 is you can do some very basic, sharing of information. Level 2 being we can do some bi-directional interfacing, right up to kind of a level 5, where it's not just the data that you're sharing, but the actual semantic meaning, and everything goes in context, and it's supporting, the complete patient pathway. I think that gives you the roadmap, so if a vendor is, say, a level 2 vendor, then that's where they are, and that's what you can expect they'll be able to do. But then you could equally say that we are looking for a level 4 type vendor, because we want these capabilities from the vendor. So it then gives you a discussion point with that vendor. You can say, well, at the moment, we don't think your interoperability is where it needs to be to support our system, our system-wide approach. So it then becomes a discussion about, okay, what's your roadmap for delivering that? The vendors that show they've got the roadmap to deliver the interoperability that's needed to deliver, because at the end of the day, the digital shifts that West Streeting talks about, from prevention, from cure to prevention, from analog to digital, and out into the community, that is absolutely 100% dependent on better interoperability. That, or a single system across it, across all organizations. And I think that second option is just going to be monstrously expensive. And to be honest, it's not really been proven in any market anywhere. So I think having the maturity model, having that baseline, it shines a light on the risk right from the start. So you can see, transparency on data assets. So having that baselining forces you to map how data is structured, stored, exchanged, and it immediately shows whether your EPR or other systems are relying on any proprietary formats, custom APIs, all these little things that can catch you out. Sorry, are we having some technical difficulties?
No, it's fine. I can hear you, but I can't see.
Switch the camera on and off. Oh yeah, I've just switched the camera on and off.
I heard all of that, Andy, and I understand that people may not, understand what you mean by proprietary systems and APIs, etc. But in essence, what you're saying is that these EPR systems have to coexist in a community of several other systems. We know the average trust alone has around 200 clinical systems, and that can be a small number. So interacting, integrating, being interoperable with those systems, whether it's through an open piece of code, an API, or whether it's a full integration where things are kind of going bi-directionally, it's a ball of wire that just can't be undone, and therefore that's where these layers, these data layers, these EPR systems ultimately come in to help bring all of that together. But equally, it's got to be done in an open and transparent and technically possible way to allow for that bigger piece. Is what you're essentially saying, which totally makes sense.
Exactly. Right? And the point about proprietary standards. So I'll give you an analogy. If you've got a Tesla, Tesla electric vehicle.
I do for now.
Probably politically not the most choice at the moment. But one of the most attractive things about having a Tesla is the charging network. So the car can be fantastic, or whatever the car is. But one of the reasons you may want to consider buying a Tesla is because they've got all these superchargers, so you can get a much quicker charge compared to other vehicles. Now, what we're seeing now is other vendors starting to use the same standard as Tesla. So that's an example of standard. So if you had so Tesla kind of had that proprietary advantage to begin with, but now they haven't. So that's the difference between proprietary is if it only works for one vendor. You know, if it's an open standard, then all vendors will share. And it's things like standards in the past, VHS versus Betamax, being an example of one standard winning over others.
Yeah, no, 100%. So you mentioned Wes, and obviously we know that there's lots of announcements that have been coming out recently. There'll probably be more today with the Labour Party conference, etc. And we've heard a lot about the NHS app recently as well. And you mentioned it before, actually, about citizens and patients having access to their data. So what would you say will be the best way to factor kind of citizen control of data into long-term return on investment, or do you think actually that's not going to happen and that's not possible?
I think it absolutely has to happen. So I think it's difficult at the moment. So that's a great example actually of proprietary. So at the moment, and this is true in the States as well, lots of vendors have got patient portals, and there's lots of individual patient portals. So it's quite possible that if you're a patient or a citizen, because you might not be ill, dealing with multiple organizations, that you have to log on to different portals, so you've got a fragmented patient experience. Now the NHS app has the capability to bring that, they call it the single digital front door, to bring all those together. So I think the NHS app has got tremendous potential. I don't think we're using it to all of its potential, but for me, investment in the NHS app and in the single patient record. So I think the two things go hand in hand. So the NHS app sitting on top of the single patient record, and the single patient record, in my view, should be a co-produced record. So that enables the clinicians to write into the record, as they do at the moment, but also the citizen or patient to be able to review and update and comment on that information as well, because the clinician will understand the condition better, but no one knows their own body better than the patient. So I think having that co-produced will result in better outcomes. And again, we see this in Sweden. They gave citizens access to their patient record years and years before we did, and it's quite controversial at the time, because clinicians don't write. Normally using language, they don't expect the patient to read the record, so it requires a change in culture. But how do you factor into the return on investment conversation today? So, because most of the ROI models are still based around provider-centric systems, I think through is to shift the cost curve. So citizen-controlled data reduces duplication. People don't have to re-enter details, carry papers around, or repeat tests, because the records are always with them. I remember my dad. My dad was much older than my mum. He passed away about 10 years ago. And my mum used to have to kind of take him around all these different appointments. She was the glue. She was the glue that tied everything together, because he was bouncing around these different healthcare provider organizations, and it was my mum that relayed the information. And that's where I think it kind of assumes that happens, whereas it's a co-produced record and the citizen's got input into it as well. I think you will get massive efficiency savings, and it will unlock new value streams. So when citizens consent to share the data for research or innovation, it creates a new pipeline of value, from population health analytics to clinical trials, recruitment for those. So boards should see it as an asset that grows in value over time, but only if the data is accessible, portable, and trusted. And then the third thing is it enhances the trust and engagement. So empowered citizens are more engaged citizens. Better engagement leads to better adherence, fewer DNAs, improved outcomes. So all of that kind of translates directly into long-term return on investment, healthier populations, and less to care for.
Yeah. Yeah, it's funny, isn't it? Because before, when we were talking about those benefits, it was none of what you've just said was kind of mentioned, but they're obviously additional ones as well,
Yeah,
aren't
yeah.
they? And giving you know citizens and patients access obviously has pros and cons too, doesn't it? But it almost feels like there's so much that we're not necessarily kind of bringing together within within organizations that you know that patient and citizen access may have to continue to be limited until that till the data is mature at an organizational level, if that makes sense.
Yeah, and I do see that the catalyst for change will be the single patient record and the NHS app. Investment in those areas, joining up what we've got. I think it will be a huge step forward.
Yeah, no, 100%. Cool. Okay, so how can a bit like the intro question beforehand, how can trust stop benefit realization becoming a tick box exercise?
So yes, I suppose. I mean, why does it become tick box in the first place? I
Yeah,
suppose if metrics are generic, if they're not linked to what this board really cares about. So it's just and I suppose there is a real temptation to share business cases, but you could end up with a kind of diluted, watered down benefits case rather than what this board really cares about. So I think making it more personal and more local is a good thing.
yeah,
Don't park the responsibility with the project team.
yeah,
Seen that a lot.
yeah,
It has to be embedded in operational ownership, and that will depend and vary very much dependent on the culture of the organization that's involved.
yeah, yeah,
And as you said earlier, it's not a one-off thing. So don't just measure them once for the business case and then forget about them.
yeah,
Keep
yeah.
them up and and keep measuring them. So I
It,
think
it
how to break that cycle, it'd be interesting.
it sounds like, as much as there needs to be dedicated resource on the interop side, there needs to be just as much kind of support around benefits tracking and monitoring, the outcome, and not just kind of letting that business case sit on the shelf, but actually keeping it as a live document. So this is what we said we would achieve. Are we actually achieving it?
Yeah.
Um,
So yeah, anchor the benefits in board priorities. So get C-suite really owning these issues. So
mm,
if the coup is battling bed flow, measure discharge times. If the CFO
yeah,
is worried about how much they're spending on locums,
mm,
track agency use. So it
mm.
has to be real ownership at the C-suite.
Yeah, no, 100%. Well, there you go. We've covered a lot, Andy. We've got to the end of the questions I wanted to ask. There was just one other thing I wanted to kind of say and ask before we maybe come to some questions from people that have been listening. So please feel free to put some in the chat. I know we spoke about AI. Just for information for those that didn't see it and didn't necessarily get the email. The EPR network did actually recently publish a paper on AI and the role of EPR, in the new world. So I think that the link might be coming into the chat. So please do look at that and download it and give us your thoughts engage in the conversation with us. But final thoughts final thoughts, number one, and number two, final thoughts in particular around the use of AI. With all of that said, do you think AI will kind of fast track some of these, necessities? Do you think it will become a friend or foe of the, interop world? And, where do you kind of see it going? If we were sitting here in even 3 years' time, would the world look really different because of AI, or would it just look different because we got a bit grayer,
So yes, it is going to look different. So I think absolutely it's going to be one of the biggest changes we've seen since the internet, I would guess. I think we're in at maximum hype at the moment and just starting to, what's the Gartner cycle? Enter the trough of disillusionment or whatever, because I think it's been overhyped. There's the bubble around it, and there's probably going to be a rebalancing.
Yeah.
I think AI is really interesting in interoperability. I'm hearing now of something an associate of ours, David Hancock, told me about conversational interoperability. So large language models using kind of natural language to deliver interoperability. I think that's fascinating. The problem with large language models, as we know, they do tend to hallucinate. So yeah, I don't know, there's an element of risk there. I think AI, one of the really interesting paradoxes of AI is I've had people say to me, well, it doesn't matter about the state of data in the NHS at the moment because AI is going to sort it all out. It will just be able to understand the data and work out what it all is and do that. And I thought that sounds fantastic, and I want to believe that's right. I actually spoke to some real, like proper AI experts on this, and they said, yes, that's true. It will be able to do that once you've trained it. So first of all, you have to train it with good quality data. And we don't have that good quality data. So that's the paradox. We need to create the good quality data, train the AIs, and then we won't have to worry about the data so much. But we can't do that until we can't train the AI until we've sorted out the data issue first. And I think the final thing to say on AI is and I think this is just generally about AI, not just in healthcare, is what we're seeing is AI does not replace humans. It doesn't replace humans. It enables humans to do things, to do more. Yeah. And to be more creative and more productive. But I don't think it replaces humans. So don't try and replace humans with AI. The other thing is, with the exception of ambient scribes, I think using AI for clinical use is just too risky at the moment. I think it's about, and I'm guessing, a few years away because of this data issue. Because until you've got the source of truth where you can absolutely trust the data, and I come back to the earlier, the allergies example. So if you look at shared care records at the moment, they pull data from multiple sources and they present it to a human being, and it might present that a patient is allergic to eggs or not allergic to eggs. They've got literally conflicting information in front of them. So a trained clinician will know what to do. They'll look at, which data they trust, and they've got that view. And I wouldn't feel comfortable with an AI doing the same thing at the moment. So I think the AI, certainly in the initial instance, needs to be given clinical facts to work with. So the focus of AI at the moment, I think, should be on areas that are where there's a human in the loop, and it's normally quite repetitive, boring work, or there's a shortage of humans to do it and we need to get humans to be more productive. So clinical coding being a classic example. So I think AI is absolutely going to change everything in ways that we can't even imagine yet. But there's a lot of hype at the moment, and without good data, AI is not going to be. We're going to have to sort the data. That's the issue. Interoperability and high quality data are both prerequisites for safe clinical AI.
Well, as the saying goes, rubbish in, rubbish out, right? So we've got to sort that data out. It's got to be cleansed. It's got to be right. That's super. We've got through 57 minutes there. So just a bit of housekeeping from us before we conclude. So as I mentioned at the beginning, we're doing around 15 of these webinars, one for each network member, of which SI2 are a member. And so we've got Ready Computing coming up in a couple of weeks on the 16th of October. A similar, theme, I guess. It's a working title, but talking about systems integration and interop to deliver the true benefits of EPR adoption. So that will be a really nice follow-on, I think, from some of the things we've spoken about today. As I mentioned at the beginning, we are continuing with our EPR Summit series in Wales in November, and then next year all four corners of the UK. So if you'd like to come to Cardiff on the 18th of November, we'd love to have you. The spaces are limited, so please do come along if you can. And then a couple of months later, on the 11th of Feb, we'll have our England EPR Summit, I think in Birmingham this time. So if you'd like to join the waitlist and come along to that, that would be super. Obviously, if there's anything that's kind of come up today, questions, comments that resonate with you guys, please reach out to the network or to Andy through SI2. I think some LinkedIn links will be going into the chat, so feel free to connect with us. I think we'll be sending out feedback forms, so please do fill that out when you get the slides and recording in the email. 2 sets of thank yous. Just thank you very much to Andy for coming along today and giving some of that 35 years of experience and kind of sharing some thoughts with us. And
Thanks
also
for having me.
thank you. And a big thank you to HIC network community marketing teams. So Rhiannon, Colleen and others that have helped to make today possible. Thank you very much. And of course, thank you to everyone that took time out today to join us. So we will, and thank you for that comment, Neil. That's great. So we will leave it there with 1 minute to go. Have a great afternoon, folks. Look forward to engaging with you. Please download the white paper. Please come to the summits, and please send questions, comments to us offline. So thank you very much and have a good day. We'll see you all soon.
Thank you.
Thank you.